Good morning, everyone. I'm delighted to welcome you to our Friday morning community of practice session. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. Our department is delighted to bring you these sessions every 2 weeks together with the Ontario College of Family Physicians. And I'm going to turn it over to their president-elect, Mehle Kuminen, to introduce the session.
Thank you, Tara. Good morning, everyone. I'm pleased to be here. My name is Mehle Kuminen. I'm the president-elect of the Ontario College of Family Physicians, just filling in for our president, Liz Maga. We have an excellent session planned with some great speakers today. And just a reminder to all of you that this is a Maine Pro accredited session. Details will be sent to you following the session via email. So just moving on to the land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories we are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from the land traditionally used by the Haudenosaunee, Anishinaabe, and the Neutral peoples.
Thanks, Mehle. For today's reflection, I wanted to share this deeply moving and personal article written by one of my colleagues, Dr. Suzanne Schuch, and a colleague of hers, and where they talk about, I think, how Canada's healthcare system fails Indigenous people over and over again, but how it really did fail their own parents during COVID, and how we can do better, and some of the answers, to addressing the disparities Indigenous people face really lie in strength-based, community-based initiatives that are led by Indigenous people, some things that they've started themselves. So please take a read if you haven't read this already. Next slide. So as usual, our sessions are building off one another. We've been talking about Omicron and therapeutics for some time. So if you've missed those past sessions, please do watch the recording, and this recording will also be up online. Usually it'll be there today along with the slides, and usually a few days later we post a summary of the Q&A as well. Next slide. So without further ado, I want to just have the panelists introduce themselves. I'm really excited for this session. I think it's going to be really practical and useful for all of you. Next slide. And of course, delighted that we have our co-host with us today as well. Next slide. So Rosemary, I'll turn it over to you to introduce yourself first and speak to your disclosures.
Hi, my name is Rosemary Lau. I'm a family doctor that practices in Scarborough. I've received an honorarium from the OCFP, and also I receive a stipend at the Scarborough Health Network, DFCM, for research leave. I have no conflict of interest. Thank you.
Ed?
Good morning. My name is Ed Etchels. I'm a general internist at Women's College and at Sunnybrook. No disclosures, received an honorarium for today.
Zane?
Hi, everyone. I'm Zane Chagla. I'm an infectious disease physician at St. Joe's in Hamilton, and have speaker and advisory work with GSK, Roche, and Merck, as well as long-term grants from Gilead. And actually, that should be Roche, not Merck. That was a typo, for COVID studies, and have received an honorarium for today.
Thanks. David, do you want to go next?
Sure. Good morning, everyone. I'm David Kaplan. I'm a family doctor in North York, and I receive salary support for my role at Ontario Health as the Vice President of Quality, and an honorarium from the OCFP.
Mehle?
Yes, hi everyone. I'm a family physician. I practice in Cambridge. I sit on the Echo Chronic Pain and Rheumatology Advisory Board, and I also have received a stipend for some work at the OCFP on our virtual care working group and COVID task force.
Thanks. And I'm Tara Kiran. I've listed some salary support and grants I've received, and speakers honorarium. The only ones from for-profit companies are Gilead and Staples Canada. Gilead for a grant on Hep C, which doesn't pose a conflict for today. Next slide. So of course, a big part of this is your questions and our panel does a tremendous job trying to answer them. So we do encourage you to put your questions into the Q&A. I have to say, I'm surprised that there isn't any in there already, because usually you guys know what to do and come here with your burning questions, and usually they start up right away. So please do put your questions in the Q&A, but use the chat to connect with each other. If you have resources to share, if you just have a remark or a joke you want to put in there, please do. I think all of us really appreciate this safe space to connect with each other during this difficult time. Next slide. I know it's been a particularly difficult week for so many of us, particularly those of you who are living and working in the Ottawa region. And thank you today for joining us. We hope that today we're going to be able to give you some practical advice that is really going to be helpful for you in your practice. We're going to start by hearing from Rosemary about the views from the front lines. What is it that doctors in Scarborough are seeing and getting challenged with? And hopefully we can talk a little bit about that and address some of those challenges today. I think we'll then move on to Dr. Ed Etchells, who's going to be talking about outpatient management of mild COVID and giving us a really practical talk, walking us through some of the medications and also where that COVID clinical assessment center piece fits in. David Kaplan is going to then move on to tell us a little bit more about the resources that relate to supporting outpatient therapeutics at this time. And then we're going to hear from Zane, who's going to talk about the, what's the latest in Omicron and the latest in vaccine evidence. And then, of course, throughout, we'll have some Q&A. So just wanted to put that agenda out there for you so you know what to expect. Next slide. So I'm going to turn it over to Rosemary Lal to get us started. Thanks, Rosemary.
Okay, good morning. So Tara reached out to me and said, what's happening and can you update us? And I thought instead of giving my perspective, which is very limited, I sent an email out to the colleagues in Scarborough, and within 2 days, I got over 24 responses. So thank you very much. And these are some common themes that arose. And for anyone who likes to look at pictures, this is the Scarborough Bluffs. We're very proud of this landmark. Next slide, please. Let's talk about in-person versus virtual. So we have a gamut. Some people are only seeing 100% in virtual. Other people are seeing 100% completely open in-person visits. But we find that most of the offices said they're seeing around 25 to 50% in-person versus virtual. Next slide, please. So this is some information that DFCM Quality and Innovation put together. This is from a survey of about 14 of the teaching sites. Quite a few doctors participated. And I just want you to look at the red circles. So in 2020, we found that the in-person was quite low. And then in 2021, we were able to increase that by quite a bit. And then pay attention to the blue circles. And this is just my little pet peeve. Video, quite low across the board. Fits, FOs, FIGs, and video actually hasn't really increased that much. And some of the comments that I received is that OTN is really difficult to navigate with respect to our patients and our physicians. Telephone remains the dominant mode of communication. Next slide, please. So this is pretty obvious, I think, to most of us, but I thought it bears noting. Why are we seeing more? Well, we have more PPE. We have effective vaccines now, and so we feel protected, and we know a little bit more about COVID-19. However, in December and January, our enthusiasm for opening up was decreased because of Omicron. Next slide, please. So let's talk about themes about patient expectations. And again, I don't think this is anything new for people on the call today. Telephone visits are easy, right? Patients love it. Some people actually don't want to come into the office for various reasons, and people can put in the chat whatever they've experienced, but there are many reasons for this. I also see, and we note that patients are booking more appointments more often. Is that because they're more anxious? Is that because it's easy? Is that because it's, oh, doctor, it's just a phone call? I think all of the above. Then we've also noted email medicine. And I've had several people comment here's what I want, send me the referral, and then why do I need to talk to you or book me an appointment? And as a result, some doctors are just resorting to, you need to come into the office, and they find that that strategy is successful for decreasing unnecessary quote unquote visits. And then of course, there's our group that only want in person for various reasons. Next slide, please. So what are people seeing in the office? What are physicians and nurse practitioners seeing in the office? Babies, we've never stopped seeing babies. Pregnant women need to be seen. And especially sometimes their OBS colleagues aren't able to see them in a rapid fashion. Sick children, yes, we are seeing those. Ear problems, I can't figure out an ear problem on the phone, they need to come in. We're trying to catch up on our PAP tests. We're doing immunizations, we're doing injections, and whatever we can't deal with on the phone, we're asking to come in. And so let's note the role of phone triaging either by the front staff or, and also the role of emails for sending us your rashes, and always preface, please send us rashes of appropriate places and nothing that's going to shock our front staff. Okay, next slide, please. So again, not news for anyone on the call. What does this have an impact on the office? Increased workload driven by patient demands. Our physicians and our staff cannot keep up. We can't sustain this. And we've experienced staff shortages with Omicron. So probably since the beginning of January, I'd say we've been running 2 to 3 staff short, and that causes chaos. And that has also been echoed in some of the emails I've received back. Next slide, please. How are we doing? How are we doing as a group? Well, there's lots of burnout and lots of reasons for that. And everyone acknowledges that. I think we need to move on to what are we going to do to improve that? Many of us rely on our colleagues for support. I have to mention this too, HRM issues. We've had Epic roll out and we've been inundated with duplicates, triplicates. We need to work on that. Lots of outside use with telephone calls. It's so easy to pick up a telephone and speak to someone because you see it on the bus. See a doctor within 2 minutes. See a doctor in 2 minutes. Lowered preventative care for various reasons. Mammograms are booking 2 to 3 months out. People don't want to come in for their pap tests, and honestly, I can't comment about why fits aren't being done. And then I must note this, access to mental health and specialists. And I am going to directly quote from 2 physicians. One yesterday sent me a really, I think, important quote. Mental health is going to be our next pandemic. And another colleague of mine said, just trying not to have our clinic shut down. And she was responding to the fact that we don't know what's coming in. Are we going to have an outbreak of Omicron in our office? Next slide, please. With respect to the use of the ILI clinics, a third, like everything else in medicine, I think, many physicians don't actually use them. Some physicians are really grateful to have them and use them easily. And with respect to ours, I've found that there are some difficulties with access with respect to telephone and emailing, and because perhaps our patient population isn't as facile on the internet to book an appointment. Next slide, please. My last slide. Let's talk about our new therapeutics. So early days all across, early days at Scarborough. And the first quote is, having successfully referred a high-risk patient for, and I'm going to mess this word up, so I'm not going to say it, but monoclonal therapy at SHN site. Very impressed, prompt response. He received infusion the same day, got HRM report same morning of the referral. Clearly a happy person. However, on the lower side, you've got the system is ridiculous because you can only refer them there with a positive PCR test. But no one except for healthcare workers can have a PCR test. And I think we need clarity around that. As I said, early days. Next slide, please. Thank you. I'm finished. And again, just a shout out to all my colleagues who actually responded and gave me their opinion, because that took some time out of their day. Thanks.
Thanks, Rosemary. I think, you've really captured what so many people are experiencing. You just need to take a look at the chat. I think people are absolutely share your observations about things, like the increase in demand around mental health specialists being backlogged and us having to do more, frustrations with HRM and how video doesn't really meet patients' desires or needs. It's not really what many patients want. So you'll see in the chat that you've really captured, I think, what many of us are feeling. And So thank you for that. I think that you ended with just this access piece around how do we help our patients navigate the COVID clinical assessment centers and access therapeutics. The people are using those centers in variable ways as family doctors and as patients. And then also when, I think the actual experience of patients is different across because perhaps these are run differently. So we're delighted to have Ed Etchells talk about that. Just before I turn it to Ed, I just want to remind people that, and I think I forgot to say this explicitly this time, that we will be prioritizing the Q&A that gets the most thumbs up. And I'm going to turn it to Ed first to do his bit, and then we'll move to some of that Q&A before we get to Zane. But just do vote with a thumbs up if you like a question, rather than enter in your own version of the same question, because it's more likely to be asked if more thumbs up are there. And I do see that there are two burning questions about boosters and vaccines, and I'm going to wait for Zane's part to kind of address those. Okay, Ed, so over to you, just building on this. So, Rosemary gave a couple of comments from her colleagues, in their experience, and I don't know if you wanted to comment on that. And I know, of course, you're going to be walking us through a little bit about what to do from your vantage point as someone leading a COVID clinical assessment center.
Sure, thanks so much for inviting me. It's a real honor to be here. At the end of this session, I hope you'll know the 6C method for managing mild COVID. Next slide, please. So our patient is a 59-year-old woman. She calls you because of fever, sore throat, cough, reduced appetite, and mild diarrhea for 2 days. She has no shortness of breath. She did a home COVID rapid antigen test, which is positive. Her medications and relevant health history include etanercept every 4 weeks for rheumatoid arthritis, empagliflozin 10 milligrams daily for type 2 diabetes, venlafaxine for depression, apixaban for atrial fibrillation. She actually had a TIA 4 weeks ago, and that's when the atrial fibrillation was detected, and amlodipine for hypertension. Next slide, please. So the 6C method is consider alternative diagnoses. This is a slam dunk case of mild COVID, but COVID has not cured the world of other illnesses. We often see patients actually have other things wrong with them. My favorite case this week was COVID-associated hearing loss, which was due to earwax. Next key issue is comorbidity management. No matter what is wrong with the patient, you have to manage their comorbidities. Next, COVID severity assessment, COVID risk assessment, COVID specific treatment, and the most important part of our management, call patient tomorrow. Next slide, please. So I already talked about alternative diagnoses. This case is straightforward. I'm not going to pursue other possibilities. Comorbidity management is extremely important, though. This patient's on etanercept. She needs to be told to stop it for at least a week until she's better. She's on empagliflozin. She's not eating. She's having diarrhea. She has to stop that drug, or otherwise she's at risk for euglycemic diabetic ketoacidosis. She's on amlodipine. She's not eating. She's having diarrhea. You at least need to know what her blood pressure is, or make sure that she's not having symptoms to suggest postural hypotension. And that's important no matter what the ultimate diagnosis is, essential to management. Next slide, please. Next is the COVID severity assessment. Next slide. So it's all about the breathing. Mild COVID, oxygen sats 94% or more if you're lucky enough to have an oximeter reading over the phone. Are you short of breath? Can you go outside? Can you go up a flight of stairs? Moderate COVID, oxygen sats 90 to 93%. 93% is a good mark on a math test, but it's a terrible mark in respirology. Short of breath on minimal exertion, within the house, on the flat. Severe COVID, oxygen sats less than 90, short of breath at rest. I'm only going to talk about mild COVID today because most patients are outpatients with mild COVID. Next slide. So next is the risk assessment for those with mild COVID. The purpose here is to identify patients at highest risk for progression to moderate and severe COVID, so-called tier 1, tier 2 patients. Next slide. So these are the patients at highest risk for progression. Immunocompromised, like our patient, She's on etanercept, a TNF blocker. This characterizes her as immunocompromised. The next criteria are related to age and primarily vaccine status and risk factors. So age 60 or more unvaccinated, age 50 or more unvaccinated, First Nations, Métis, or Inuit, age 50 or more unvaccinated, plus any Ontario Science Table risk factor, and I've listed them at the bottom. So I want to say thank you all, because by vaccinating your patients, you've taken them out of tier 1 and tier 2. So most of the patients we see are actually tier 3, tier 4, or lower, and we don't need to intervene because they generally do great. So thank you. Next slide. So once we've done a risk assessment, then we can target COVID-specific treatment. Next slide. So for tier 1, 2 only, for the highest risk patients, we first think about sotrovimab, intravenous monoclonal antibody. If that's not going to work, either because of practical issues or allocation issues, then we think about nirmatrelvir, ritonavir. I'm going to talk about those in some detail, and then we'll talk about fluvoxamine and budesonide at the end. This patient actually didn't want to go to a clinic. She didn't want an IV, and she wanted to talk about the pill first, so we talked about that first. Next slide. So to give a patient nirmatrelvir, ritonavir, they must be a confirmed case, so you need a PCR or a healthcare administered rapid antigen test. So this patient's home test would not qualify. You have to be within 5 days of symptom onset. And I found some confusion on that. Symptom onset is labeled as day 1. So you have to start the drug by day 6, because 1 + 5 is 6. We can all easily identify absolute contraindications: EGFR less than 30, pregnant, child's Pew class C cirrhosis. So these are patients with ascites, jaundice, and edema, or untreated, uncontrolled HIV. You can't give them the drug. If you can get through those 3 hoops, then you need some help and advice, because it's a lot of work to prescribe this drug. We're happy to help you. Next slide, please. If you called us about this patient, we would always review all 6 steps. We would help you get a rapid antigen test or a PCR if needed. We would get the EGFR if needed. And then we would spend about 30 minutes thinking. Next slide. And to remind me what to think about, I always think of this picture, because this is Elton John, and he has a wart. Next slide. And this is the drug. So nirmatrelvir is the 2 salmon-colored pills, and the ritonavir is the white pill. The only purpose of ritonavir is to be a drug-drug interaction. The ritonavir impairs your liver's ability to metabolize the nirmatrelvir. So this drug is a built-in drug-drug interaction, which reminds me that there's all sorts of other unintended drug-drug interactions that can occur. Next slide. And this is how I try and conceptualize them, because it's hard to get my head around these things, but these are the concepts. So the first category of drugs that are hard stops, you cannot mix these drugs with nirmatrelvir, ritonavir, are drugs that are CYP3A4 inducers given to the patient anytime in the last month. These drugs will ramp up the metabolism of nirmatrelvir, so it won't work. The patient will get no value from the drug. These are the anti-seizure drugs like phenytoin or carbamazepine, some of the metastatic prostate cancer drugs, rifampin, and St. John's wort, as opposed to Elton John's wort. But that's what reminds me to think about these things. The next category of drugs are CYP3A4 substrates with long half-lives, because if you mix nirmatrelvir and ritonavir with these drugs, the patient will get toxic levels of their other drug for a prolonged period of time, absolute contraindication. And the offenders here would be antiarrhythmics, type 1 antiarrhythmics like procainamide or flecainide, as well as amiodarone. Certain antipsychotics, so as soon as I hear that the patient's on an antipsychotic, I got to go to the list and just check. Not all of them, but some of them. And the pulmonary hypertension drugs like high-dose sildenafil, absolute contraindication. The patient will just get severe hypotension. If you can jump through those hoops, then you still need a pharmacy consult because there's so many other drugs that it's impossible to remember them. I wouldn't even attempt it. If you don't have a pharmacist handy and you have a good medication list, you can go to drug interaction software. There's a very good software published from the Liverpool group. And I'll just show you what it looks like. Next slide, please. So I've typed in on the left the nirmatrelvir ritonavir. In the middle column, the patient's 4 drugs, and then venlafaxine, amlodipine, apixaban, and empagliflozin. And on the right, you can see the red warning saying you cannot mix apixaban with this drug, and you better be careful with the amlodipine. If you give the patient apixaban and this drug, they'll start bleeding. You have to stop the apixaban for the entire course of treatment and for 3 days after treatment. Well, this patient just had a TIA a month ago. I'm not stopping her apixaban. I told her, I'm sorry, you can't have this drug. Next slide, please. I said all that already. So next slide. So we went back to sotrovimab. So this is the intravenous monoclonal antibody, single dose. You require a positive PCR or rapid antigen test administered by a health professional within 7 days of symptom onset. Basically, there's no contraindications. There's some weird, rare allergies that I've never come across, but otherwise the patient generally tolerates the drug very well. So now she's interested. Our process is, I don't have the drug. I have to call infectious disease at UHN. They have to agree that it's indicated. Then I fill out the forms, fax them to the clinic, they get reviewed, and then they hopefully call the patient within 24 to 48 hours to do the infusion. I do need the patient's positive PCR though. So I told her to go home. I had all the paperwork ready, and I talked to her the next morning. Next slide. Next slide, she said, oh, I feel better already. I had a good night, no fever, good energy, good appetite, just the cough. I don't want to get treatment.
Sorry, Ed, I'm just going to pause you because actually I missed this. Can you just speak up a little bit? Because I think some people are having a hard time hearing.
Yeah, my apologies. Do you want me to go back to the first slide? Just kidding. So the patient's already started to improve, and we decided not to proceed with sotrovimab. And this is a tip. The best way to assess disease progression is to assess disease progression. It's hard to predict what's going to happen today, but it's very easy to call the patient tomorrow. As Yogi Berra said, predictions are difficult, especially about the future. So she said, is there anything else you can offer me? Next slide, please. So we talked about fluvoxamine. This inhibits the cytokine response. So it makes a lot of sense if the patient's having fevers, aches, chills, and lethargy. But it's also a drug with many drug-drug and drug-disease interactions. You can't mix it with caffeine. You shouldn't mix it with other SSRIs or SNRIs. And there's a ton of other drug-drug interactions. In her case, I said, it doesn't make sense. You're on venlafaxine and you don't have the cytokine symptoms. So I'm not sure it's going to make you feel much better. And you're already getting better on your own. And the last is budesonide inhaled. It's anti-inflammatory, it's antiviral. It makes a lot of sense if the patient's primary problem is coughing, wheezing, or some shortness of breath on exertion. She found the cough annoying, so I wrote her a prescription for budesonide. Next slide, please. Unfortunately, there is no budesonide in the pharmacy because everyone's writing prescriptions for budesonide. My opinion is it's probably a class effect. This could be argued, but I think any appropriately dosed dry powder inhaled steroid should be fine. Here are some practical alternatives. The fourth option is to give the patient budesonide with formoterol, that's Symbicort. This makes sense if the patient's wheezing and has no angina or arrhythmias. I would be nervous doing that otherwise because you're going to give the patient a beta agonist overdose for no good reason. Please emphasize rinse and spit after use to minimize systemic absorption and local side effects of all of these drugs. And there's the link for a good video showing patients how to use their dry powder inhalers. Next slide. So we gave her budesonide. We called her again the next day. She was feeling great. We gave her advice on comorbidity management. And we told her that if the cough persists for more than 14 days, she should get reevaluated. Next slide. So I hope you found the 6C method useful. We find it useful. It works. We're here to help you. Next slide. Thank you.
Thanks so much, Ed. Really appreciate you walking us through that case. I think for me, case-based learning always helps to bring it home. I'm just going to put into the chat the Ontario Science Table kind of summary around the therapeutics, which I think is a great reference for folks. It's also on the Center for Effective Practice website. I'm going to just ask Ed, you run a COVID clinical assessment center, and this is a question also for you, Zane and David, to weigh in. Who should family doctors be sending to these COVID clinical assessment centers? I think some people are referring to them also as ILI clinics, and I think those are the same things, but I just wanted to get clarity on that. I think there were other people in the chat just saying that sometimes they're a bit underused. People don't necessarily know about them. They're not sure if they're sending the right people there. So who should be sent there? And then I guess one follow-up question to as well, Ed, is I got the sense that in fact, it's not just a place you can send people, but maybe in your case, it's a resource to physicians that you could actually call and get advice about a patient that you don't necessarily physically send. So wonder if you could clarify that, and I'll turn to you first, Ed, and then let Zane and David add on.
Sure. So the purpose of the CCAC is to provide in-person assessments of patients with COVID. And to guide therapeutic management. We also do diagnostic assessments. We can do lab tests, and we can manage comorbidities. Having said that, we're happy to talk to you on the phone first, because sometimes you're not sure if the patient should be physically assessed. We have a navigator number, which I'll put in the chat. Basically, the navigator will talk to you. There's always a doctor physically there, and we'll review the case with you and make a decision together. We're primarily interested in tier 1, tier 2 patients, but we're also happy to help you with the management of lower risk patients, especially those with a lot of comorbidities or patients where there's some diagnostic uncertainty.
That's really helpful. And I saw, Zane, that you were nodding. I wonder if you wanted to just add in, because I know you're involved in Hamilton in the COVID Clinical Assessment Center.
Yeah, absolutely. I agree with that. Absolutely. Tier 1 and 2, this is the place to get them assessed, and often again starts the trigger for either Paxlovid or sotrovimab utilization and assessment. And I think especially manage the comorbidity management, the dehydration management. Again, the people that may not fit tier 1 and tier 2, but may need a bit of medical support to get through or diagnostic support to get through their COVID. And I think the other population we're starting to see a little bit, which is reasonable, is kind of people day 14 who are still persistently having symptoms, maybe not sick, hospitalization sick, but where there's concerns of secondary pneumonia, there's concerns of other causes of their dyspnea, where an in-person assessment may benefit with just kind of that diagnostic dilemma. They may not be eligible for treatment, but just to make sure that there's nothing else going on in those individuals with an in-person assessment.
And do you, and I don't know if you guys can answer this, but I know each one is set up differently. Is that kind of navigator function that Ed described present at other COVID clinical assessment centers? I don't know if you guys know that, or David, if you know that.
I mean, they're all set up differently. Some of them will not do diagnostics. Some of them have diagnostics on site. So I think it is a variation on a theme. I posted in the chat, I think it is important that the COVID assessment clinics that people know, not the swab centers, the assessment centers, but the COVID assessment centers are really also meant for if you as a family physician, nurse practitioner, pediatrician, feel that you have a patient who cannot be safely monitored at home, who needs an in-person assessment, and you don't feel that you can see them quick enough, or you don't have the services you need, or it's not safe in your office, absolutely send them to a COVID assessment center. That is exactly what they're for, in addition to the high-risk patients who need or would qualify for therapy. Do not hesitate to send them.
Thanks, David. I think that's really helpful for all of you. Thank you for clarifying that. I'm going to actually go to the next slide, and maybe David, I'll let you continue to just tell us just a little bit more about that, pathway.
Yeah, sure.
Like potentially identifying somebody And then, and even that process of identifying someone who may need treatment is a really tricky one, because they have to often self-identify, and our office staff then have to get us the patient. And then how do we bring that all the way then to deciding, do we manage it? Do we send it? And then I think Ed walked us through what might happen at a clinical assessment center. And also, if we were thinking about a 3 or 4, what we would, tier 3 or 4, what we might do. But that beginning part would be really helpful for you to walk us through. So
yeah, absolutely. So I think really what's changed now in January, at the end of January, now in February, is the messaging that we had in late December, which was, if you think you have COVID, self-isolate, like if you screen positive, has now been, we need to know that patients should call their family doctor, nurse practitioner, pediatrician, if they think they're at high risk for disease. And so one of the things that we are asking, and we've provided some resources in this guidance document, is to try to communicate with your patients proactively. So, sending an email to your patients who are over a certain age or are on certain medications, have certain conditions, to let them know, if you think you have COVID, even if you can't get a swab, please call the office, because we may need to treat you. And I think that is a shift in the public messaging. And that's really what's going to get, us either IVs in arms or pills in people's mouths, because of the really short window of time that we have to offer these therapeutics. So it's that shift in messaging around communication with your practice. You think about our populations as populations at risk. These are subsets of the population that are really at risk of developing severe COVID. And I think the other one is the prioritize. So if a patient does call the office, it is really important that we do some sort of assessment within 24 hours to decide what their disposition is. If that's, an in-office visit on the same day, if it's safe to do so, or if you think they have a good story for COVID and you think they qualify for a therapeutic and they're already on day 3 or 4 of symptoms, it may be just getting them actually a warm handover, getting them to see one of the clinical assessment centers. And that's very different. We have provided, along with the Center for Effective Practice, an office, a script for our medical office assistants to help sort of do that sort of triage.
Do you want to go to the next? I think there's a couple of tools in the next slide.
Absolutely.
Actually, David.
Yeah. So this is a bigger version of what you saw in the first slide. So we sort of spoke a little bit about item number 1 and item number 2, which is that proactively engaging with patients, either in the office when you see them for some other reason, to let them know that, they're high risk and they may qualify if they ever do get COVID symptoms. And then prioritizing seeing those patients, or somehow getting their disposition figured out so you can get them assessed somewhere. And I think we've talked already about the assessment and referral that Ed did, but really starting to know what the resources are in your community. I think we've posted a couple times today a list of those clinical assessment sites. And in the slides, I think you'll see, get a sense of where the treatment sites are across the province. One of the things that I think it's important to note is, obviously we have a very large province, and what they did try to do with the Paxlovid sites is distribute them in areas where there's been a high burden of COVID. And so there is a bit of a science to where we were able to figure out some of these sites. I think ultimately it would make a lot of sense to move the pill to the patient, not the patient to the pill. But I think in the short term, this is what the decision was.
So we'll just go through just a couple of slides here. Next slide, just so you know, and we'll go to the next slide maybe, just to one more slide. Yeah. So this,
there we go.
So just this is a handout that we've developed that, I have COVID, when should I call my doctor? And it actually really outlines here some of the criteria, I think, in a patient-friendly way, so that patients can self-identify that they need to call us. So I think this is a really great handout to just really try and e-blast to your patients, let them know about, so that when if this happens to them or a family member, they know when it is that they should call the doctor. We actually do also have a handout coming out soon about treatments, just so people have that information and can be educated themselves. Next slide. And then the medical office script. This is the medical office script that David was talking about. So these slides will be circulated, but we've also circulated the link to the document that has that hyperlink in it. Did you want to say anything further about this, David? I think
no, I think, no script is going to be perfect. We really worked with a number of family physicians from across the province and some of the quality staff in my branch to try to come up with a script that we thought would capture a good amount of these patients, but it's not going to be perfect by any stretch. I think the message to the front staff should be that if they are worried about somebody and they don't seem to, meet the script exactly, just send us a message in the EMR or tap on our door and just run it by us. I think that if they have any sort of concern about a specific patient who's calling with COVID, I think we know our patients very, very well. We know sort of almost at a glance if they may or may not qualify for therapy. So I think it's worth sort of that, just the double check if somebody calls the office, because there is that really short window of time. I had a patient last week, who was 80 years old, who's on Humira, and he just called just to say, oh, by the way, I just wanted to let you know I had COVID. He didn't think that we could do anything for him. And my staff were like, sent me a message, and this is before we had a script and we sort of trained the staff. And I said, you got to call this patient back. Does he have symptoms? How many days? When did it start? And we ended up getting him Paxlovid within a day or two at Scarborough. So thanks, shout out to the Scarborough folks.
Thanks so much, David. And Alan just mentioned how he modified the script actually for his office to simplify it to 2 questions. So definitely, of course, take and modify. Next slide.
Absolutely.
And then I think you put these maps up.
Yeah, so
we're
this
not
is
going to go through them in detail.
No,
but
just to give people a sense, I just want to speak to our friends who are in the north, both on Sotrovimab. So you can see there, both at Thunder Bay and Health Science North, there are sites. If you live north in Northern Ontario, please contact the closest COVID assessment center. For the MAB therapy, we will attempt to get that Sotrovimab to your local hospital if you are in the north. So the people in the north are not shut out of accessing this therapy, but please try to pick up the phone, speak to the physician at that site. And Zane, I see him nodding. We will try to get that therapy to the patient, to your local hospital. And then with Paxlovid, it's a bit more of a challenge, but again, call your local clinical assessment center and we'll try to make things happen. It's just such a short period of time, even just try to ship pills across the north. Yeah.
So next slide, I think we'll just I think David spoke to this. We'll not keep going. Yeah. Next slide. And these are the Paxlovid slides. Next slide. People are asking about where these clinical assessment centers are. And so please do check out the Center for Effective Practice website to find that. And it probably is a good idea to figure out how your clinical assessment center in your local area is operating, because it sounds like each one is operating slightly differently. Next slide. I think there is a central referral form for IV Sotrovimab. I don't know, David or Zane, if you wanted to speak to this.
All I would say is, as of this week, and I think it's being shared by the OCFP today, the referral form is available for Practice Solutions. There are instructions how to download it into your server, and it's available as well on the Accuro form repository, and I believe later today or on the weekend it'll be available in Oscar. So you'll be able to download this form directly into your EMR, and I believe all of our associations will be messaging how to get access to it electronically.
Great, thanks. So I'm going to turn it next slide to you, Zane. I know there have been a number of questions as well in the Q&A that I think relate to things you're going to be talking about, but I thought, why don't we start with your update and then we'll move to some of these questions.
Absolutely. Thanks, everyone. So I'm going to go through just a bit of an epidemiology update for what limited amount I can, and really some vaccine efficacy updates just based on what literature is out there around Omicron. So next slide. So epidemiology update, and I put the shrugging emoji because obviously we know we can't be testing as much. So a lot of this is based on surrogate markers, sewage and other kind of highly tested populations, generating kind of what we think the community burden has been to this point, and really that informs kind of hospitalizations, ICUs going forward. Next slide. So this was the wastewater surveillance. So this is a network of 90 wastewater networks across the province. So it is a relatively reasonable scope. So, looking at community measures, and again, there is about a week delay between wastewater peaks and actual peaks in terms of clinical activity based on the literature. So, based on this, the prediction was the peak of the Omicron wave was January 11th. You can see kind of towards the last little bit of January and early February, you see a slow decline. Again, the wastewater kinetics aren't necessarily all straight up and straight down. There's a little bit of an interpretation from it. But the credible interval based, again, from the modeling from the Ontario Science Table would suggest about 1.5 to 4 million cases of COVID-19 in Ontario over the last 2 months. It's pretty staggering considering what happened. And the relative lack of people to get tested. I think if you look at testing numbers, they're somewhere around 400,000 positives over that interval. So we're at least missing 1 in 3 to 1 in 10 people during that time with testing. And then again, 10 to 30% of Ontario's population. So significant numbers there, probably reflecting why healthcare was so strained in the last little while. Even that small percentage of that 10 to 30% can lead to a significant burden in healthcare. Next slide. This is from the Ontario Science Table modeling. And some of this is also looking at serially tested populations. So workplace testing with rapid antigen tests of essential workplaces. And you can certainly see, again, at the peak, prevalences of nearly 2.5% of people walking in at any given day that were rapid antigen test positive. Which is pretty remarkable considering how much of the population on any given day had COVID-19. In that context, it is declining there. People that are repeated testers, so those who work in long-term care, healthcare workers, et cetera, kind of looking at people that have had 40 plus tests during the pandemic. And again, seeing that decline in all age groups, young and old, in those populations. And then finally, as many of you know, admission screening in hospitals, and most hospitals switched over to universal testing of everyone coming in the hospital. And again, looking at different areas like labor and delivery, pediatric units, non-COVID units, that in adult units, you can kind of see a decline in percent positivity. Again, pretty impressive that at the peak, we were seeing 2.5 to 3% of people testing positive for COVID-19 on any given day, which probably represents how high the burden was in the population at the time. Next slide. So from the healthcare burden standpoint, we are seeing obviously a reduction in hospitalizations. We obviously know about the issue of hospitalizations with or because of COVID. Both are decreasing, although it's, at least from our local data, it really does seem like that with COVID is the one decreasing faster than the because of COVID, recognizing that, now people are actually coming into care because they have COVID-19, not necessarily because they need labor and delivery care, et cetera. ICU numbers are going down. Today's, I think, census was 509 critical CRCIs. So again, seeing some declines that are a bit slower, but thankfully in the right direction. Next slide. In terms of hospitalizations, there was a significant, number of hospitalizations with those over 60 and those between the ages of 20 to 59. You can see kind of over this last interval, there were an increase in pediatric hospitalizations relative to all hospitalizations. You can see that kind of little red at the bottom of the left graph, which is relatively small. But when you break it out in terms of that number specifically, the vast majority were the under ones that were hospitalized, and a small amount across all other age groups. Some of this may have been again with, but some of them are truly people that had more symptomatic COVID-19. I don't work in a pediatric center, but at least chatting with my colleagues at MUMC, a lot of the presentations were kind of upper airway disease from COVID-19, so more croup or tracheitis in that point, which may have been the reason for hospitalization and monitoring for those that really did have COVID-19 complications requiring hospitalization. Next slide. This is the modeling in terms of range of hospitalizations. And you can kind of see here that, the modeling is a bit all over the place, to very good to very bad scenarios. And, a lot of this is very dependent on how many people we think were infected in the community more than anything else. And that's why that, range of 1.5 million to 4 million is so hard to predict what's going on in the future, because if we're closer to 4 million, there is more population-based immunity with boosters and people that have had prior infections. And so the number of susceptible people in the population has significantly decreased. But with 1.5 million, obviously that leaves 90% of the population that's still susceptible, or at least a good chunk of them that are still susceptible. So, hospitalizations could continue to increase over time. So you can see the range of possibilities, the green being more towards 3 million infected, the red being towards 2 million infected over the last while. And obviously, again, the more stabilization of hospitalizations, only in the kind of scenario where 4 million are infected that you start seeing a significant decrease back to almost our baseline hospitalizations. And ICU capacity always being challenged, and recognizing that all it takes is a small number of high-risk cases to get COVID-19, even as the decline occurs, that can really push ICU capacity moving forward. And knowing that these patients obviously stay in ICU not for a short amount of times in that sense. So again, a lot of this could be mitigated with access to early therapies, and especially amongst those high-risk individuals, as well as offering the booster shots to, again, high-risk individuals. So again, more incentive to really, strengthen these networks as much as possible to save healthcare capacity. Next slide. In terms of vaccine update, I'm going to go over just quickly the studies that have been published. There are a lot of studies that look at neutralizing antibodies, which I'm not going to mention here anymore because they're a surrogate marker and we have clinical data, and we probably should be making decisions on counseling patients based on clinical data over neutralizing antibody studies. Antibody studies are great early because they're easy to do and cheap. But now that we have population data on effectiveness of boosters long term, we probably should be using that as part of our paradigm in terms of what these actually mean. Next slide. So this is a summary of about 5 studies that have been published to date. They're all different methodologies. I will say as well, looking at some of the UK data, there is a lot of issues with hybrid immunity in that population, particularly knowing that the United Kingdom had a significantly high natural infection rate as compared to places like Ontario, where much of the immunity is vaccine only and people are immunologically naive. But I think the common theme here is number one, 2 doses of AstraZeneca alone likely offer very little immunity to Omicron in the long term. Number 2, 2 doses, does have a significant wane of effect against the infection. Again, these are estimates of infection, not necessarily severity. Looking at time since that second dose. So when you get to kind of 3 to 6 months, you're really losing a lot of the efficacy of that second dose. And that third doses do restore some of that efficacy against infection, but there is still a time-based weaning effect. And so, the longest follow-up, and I'll show some of the UK data after this as well, but the longest follow-up we see is in the United States of boosters, and really, again, in that population that got Moderna vaccine, that we see an efficacy of 39% at 2 months. Now, again, some of these studies have issues where the comparator group has also gotten COVID to a significant degree. And so it may look like the efficacy is much lower in booster doses because the control is less likely to be infected because they've had prior COVID-19. But we do see this waning of effect over time. Next slide. This is the UK data, and this data is probably the best model data out there. And as well, the UK was much further ahead in its booster campaign. So many of the adults here really did have a chance to get 15 weeks plus after their booster dose. And so this is for infection. The boxes are Delta and the circles are Omicron. And just walking through this, you can see that the efficacies certainly do change with second doses between Omicron and Delta. So from second doses, you see an efficacy right after your second dose of Omicron at about 60%, which was 90% with Delta. And at 25 plus weeks, you see an efficacy nearing 0% with 2 doses, where it was well over 60% with Delta. When you look at a booster, and this is both looking at Pfizer or Moderna boosters, you see that again, you can restore a lot of that efficacy in Delta quite easily with a booster shot to go well over 90%. But with Omicron, again, you get back up to the 70s. And then again, with time, you see this decline at 15 plus weeks down to about 40%. So, there is some challenges here saying that the booster shots are going to be complete, solutions for reducing infection. They will help and are certainly warranted in high-risk settings and high-risk individuals. I'll talk about the hospitalization element, which is still very, very preserved. But, there is probably some signal here that time will likely erode some of the efficacy of these booster vaccines more than anything else. The Moderna data is still a bit further out, and you can see the error bars are quite wide because Pfizer was the booster for a lot of individuals in the UK. So again, estimates are a little bit more wide for the mRNA. This data is being repeated every 2 weeks, so we should have an update probably next week in terms of what this data set looks like over time. Next slide. This is a study called Siren, which is done in the United Kingdom. It's a really interesting study of healthcare workers that have been serially swabbed essentially from the beginning of the pandemic to now. Their vaccine status is recorded. They're also obviously recorded for prior COVID infection. And so they were looking kind of at the interval where Omicron started becoming an issue in the United Kingdom, looking at the effects of not only vaccine but prior infection in that sense. And so these are under 65-year-old healthcare workers. They're largely a healthy cohort, so take it with a grain of salt in terms of interpreting it to the general population. But you see that people that are immunologically naive, so the comparator being people that are unvaccinated and have had no prior COVID-19 prior to November of 2021. 2 doses of vaccine takes their efficacy to about 32%. 3 doses of vaccine takes their efficacy to about 60%. And if they've had a prior infection, that probably does give some protection, 40% against reinfection. And with 2 and 3 doses with hybrid immunity, you see an increase to 60 to 70% protection with having prior COVID-19 plus being vaccinated on top. And so, there is this concept where, prior COVID may be shot 1 in some individuals. And so, there is a lot of obviously questions that are coming out of what to do with my individual that got 2 doses, got Omicron, is scheduled for their booster dose. At least we have some data suggesting that it's not urgent to get it right away, that they probably have the efficacy of 3 doses temporarily. Again, this is not, 2 plus Omicron. This is prior infection plus 2. But, at least there is some reasonable counseling to say you could probably delay things for a little bit of time, maybe a month or 3 months. NACI will likely come out with some more recommendations on this topic, but, you probably still have fairly reasonable protection from your 2 doses of vaccine plus your Omicron infection. Next slide. This is looking at
Zane, can I just ask a question about the
sure,
previous slide, just for people may be interested, just because there's a lot of questions about boosters for teenagers. Is there any data about vaccine effectiveness with 2 doses in teens compared to the rest of the population?
Yeah, the studies show it's pretty similar. And so again, VE is probably a time-based measure, right? So it really will depend on when your teen got their vaccine. If it is recent, then their 2 doses is probably functioning very well. If it's getting to 20 to 26 weeks, the VE is probably very little or very slim in that sense. So again, I think this is the trend we're seeing with Omicron, is that protection against VE is, temporally linked to when you got your vaccine more than anything else. Okay, so looking at hospitalization and serious complications. So we do see, again, 2 doses has a weaning effect. And so this is really where the booster dose really does need to be pushed into high risk populations, that even with hospitalization, 2 doses may protect against hospitalization, but that effect does become diminished at about 25 weeks. The good news is at least from data, and again, this is wide confidence intervals because of the hospitalizations with rather than because COVID-19 in the UK data set, that we see hospitalization protection of greater than 80% in most populations after their booster dose. And so, again, much more convincing data, especially for high risk populations, to get their 3rd doses, and at least looking 3 to 4 months out that protection still lasts at fairly high amounts, not as good as Delta, but still lasts pretty effectively. And then a small sub-study looking at death, and again, the odds ratio towards death being 95%, so 95% reduction in mortality amongst those who had 3 doses to a 59% reduction in mortality for those who have 2 doses. So especially those who are at the highest end of dying, again, there is some encouragement to get those 3rd doses into those incredible, to those vulnerable individuals. Next slide. This is just Ontario data looking at breakthrough infections and hospitalization rates. And again, you can see how remarkable 3rd doses do into high risk populations where, an 80-year-old's risk of a 3rd dose, 80-year-old's risk of hospitalization is at the level of a 40 to 50-year-old's risk of hospitalization that's unvaccinated. So, again, these are probably the patients that benefit the most in terms of reduction of healthcare utilization from getting a 3rd dose. We don't have a lot of data in long-term care around what the 4th dose strategy looks like, but I'll give a slide of what Israel's data was. Next slide. Looking at, again, fatal confirmed cases, and we're again really reinforcing who is at highest risk of dying of COVID-19, who has not received a booster dose. It is really age stratified here, right? So we've had 1 death amongst individuals under the age of 60 who have had a booster dose, but there are still, a difference in 2 dose versus 3 dose deaths that is fairly significant, over 150. And in the 80 plus and 70 to 79 plus, there's over 80 deaths, and the difference between the 2 and 3 dose individuals in that sense. And I put those 2 because they were the ones that were eligible for third doses, earlier than December 14th. So where the efficacy may have taken place. So, again, significant benefits to pushing it into that population. If you're having struggles, obviously counseling the 18-year-old to get their 3rd dose of vaccine, the benefits here probably aren't as significant, especially if they've had prior infection or just got Omicron. But that elderly immune compromised group is definitely the biggest target here that is missing, and really, a mortality benefit that's being seen in this population for getting that 3rd dose. I also will say it is really sad to be seeing 80 and 90-year-olds in hospital that are unvaccinated because of, almost fatal, even though we've gotten to a lot of them and the rates are incredibly high. The one-offs that haven't been vaccinated are having terrible outcomes, and they were really represented over the last couple of weeks in our hospital. And it was quite tragic to see that could have been prevented in a lot. Next slide. Lastly, talking about 4th doses. So, this was rolled out into long-term care fairly recently as part of the Omicron wave. There was only 1 preliminary data set. This is only released by the Ministry of Health in Israel, so it wasn't actually a peer-reviewed publication. But the bottom line was they gave 4 doses to people 4 months out from their booster dose. As we know, Israel was kind of the first countries in the world to give a booster dose. So a lot of those people are then now in that 15 plus week range to getting their and saw a big Omicron surge recently. And so, to those individuals, they looked at 400,000 who were over the age of 60 and compared them to about 600,000 who were 3-dose individuals. They saw about a 2 times lower likelihood to be infected and a 3 times lower likelihood to be severe. Their definition of severe is a little bit different than ours, where it's just a slightly low oxygen sat or persistent dyspnea. But certainly there were some benefits here. Again, it's very hard to see what the long-term effects of this are, whether or not there's a weaning efficacy. in that context. But, you know, again, there may be some justification here as we talk about fourth dose strategies in long-term care to really target, you know, highest risk populations who are furthest out from their boosters with fourth doses. And we'll see what the long-term care experience shows. I think that's my last slide.
I think you have a summary slide, so we can go.
Oh,
to the
yes,
next
that's it.
slide,
That's it. Sorry.
That's fine.
Yeah. So, you know, basic concepts here. Again, the future really depends on the population that's susceptible still. The ICU pressures will likely remain for some time. The VE is definitely affected by Omicron and is definitely, it seems, temporarily related to when you got your last dose of the vaccine. 3 is better than 2, and 2+ is probably 2+ infection is probably as good as 3. There's definitely a need for high risk populations to get their 3rd doses for a mortality and morbidity standpoint. And then 4th doses in the extreme elderly may be of help in certain populations. Thanks
so much, Zane. So just a reminder to everyone, we're going to be going till 9:15 because I know that there's some questions that people have. But Zane, I think you've answered a lot of them through your talk as well. But maybe I'll start by posing some additional questions to you. So I think the first question people have is sort of, is there any update on upcoming variants? So we've had Omicron. Is there anything else that we should?
Yeah, absolutely. So I mean, the one that I think is on everyone's mind is BA.2. So this is a subvariant of Omicron. It is quite genetically different than Omicron. It has some similar mutations, but it has some differences in mutations. There's not a lot known. Denmark and the UK are probably going to be our source of this because they have fairly well captured sequencing that is also linked to clinical outcomes. So that kind of patient link. At least the early studies from the United Kingdom suggest vaccine efficacy follows what we described with BA.1, that immune evasiveness towards vaccines should, you know, still be preserved in that sense. The data around clinical severity also seems to be, again, in the same ballpark as BA.1. But the transmissibility does seem to be, you know, if we talk about, you know, 35% secondary attack rate for BA.1, we're talking closer to a 40 to 45% secondary attack rate with BA.2. So there is, you know, the modeling, and I think in talking to individuals in Europe who have gone through this, you know, the implications would probably be a longer tail of this decline as compared to, and a longer and more blunted tail of this decline, rather than kind of a sharp decline in that sense that will likely be the replacement effect of BA.2. And we certainly have had cases across Ontario that have been identified.
So you spoke a little bit about boosters for the 12 to 18 group, or the need for them. So I guess a question for you, but also David or other panelists is, are there any word for getting 12 to 18-year-olds boosters in Ontario? You know, I think people made the connection as well that part of the reason they're not being prioritized is because the risk of severe outcomes for youth is very low. But wondering if you have any insight into that, Zane, and then David.
Yeah, I can talk about federally. So NACI did come up with the recommendations, immunocompromised, high-risk children and children in racialized and marginalized communities as well, recognizing the burdens were higher in those communities, and community level protection in those communities may offer a bit more benefit. From what I understand, Ontario has taken had the prior immunocompromised advice, and that those boosters have gone out. The rest of it, I think, is being reconciled at Ontario's vaccine table for kind of more expanded booster sessions, but I'll leave it to David, who probably knows a bit better from that standpoint.
Yeah, so happy to just give people an update. I can say that, so just so maybe everybody knows, in the summer, I guess, of this last summer, the Public Health Ontario and the government have created a new Ontario Immunization Advisory Committee. And so that committee, my understanding, is meeting next week to discuss a booster policy for Ontario for 12 to 17-year-olds. So I would expect to hear something next week or maybe early in the week after.
Thanks.
Now, I would only say that we have seen the Ontario table and the government not follow NACI recommendations in this, and so just because the NACI recommendation is written one way, it doesn't mean that that's how it's going to get operationalized. in Ontario, but we'll see what happens over the course of the next week and a half or so.
And am I right in saying that any teen who's immunocompromised is eligible for a third dose? Yes. So if you're immunocompromised and you're a teen, you're eligible. It's just the people who are the vast majority who are not, that we're waiting for some advice and direction, or not advice, but some direction. So Navita Yasmin asks, is there any research on how long the antibodies last after third dose? And I think, Zane, you were going to take a stab at that one.
Yeah, so I mean, the good news is you do get antibodies that last fairly significantly. I mean, again, the data around antibody persistence, is there. The problem with antibody studies is they don't necessarily, we don't know the correlates to say they could, what clinical protection people have in that sense, especially with Omicron in that sense. So again, as we're seeing in the clinical data, the persistence for protection certainly does last. I mean, 40% at 15 weeks is still something, meaning that antibodies are still providing some protection, not perfect. And the, over 80% protection against hospitalization, really meaning that, all immune effector cells, antibodies, T cells, and innate immune cells are still working very well from vaccine-derived immunity. But certainly, there is some weaning over time, and I think that's expected now until we get a newer generation of vaccines or different vaccine strategies.
Thanks. And I know a related question is people have asked is, if you have COVID, when can you get your booster? And so my understanding is that NACI is actually going to be coming out with something imminently to give a more definitive answer to that. I think on this webinar, we've heard from Allison McGeer and others that, at least 4 weeks, probably longer is better. And I see you nodding, Zane, around that.
Yeah, absolutely. And again, at least we have some data from natural infection plus 2 doses, is that you're probably functioning at the level of a boosted person in that sense. So who had never had infection. So there is some justification of waiting till, your immune response calms down and you get derive the benefits of a booster at that point.
Great. So Mahalay, the next question is actually for you, and it's from Nastia Jacob, and I think others have asked it as well. So this is related to patients calling about travel letters. So Nastia asks, I have patients calling requesting clearance letters from the US. What's the recommendation in this situation? I think there's others who've asked a differently worded but similar question.
Yeah, I think we're all seeing a lot of these requests, and we know that it does put a burden on us as providers and takes us away from the care that we're providing to our patients. So first, I'll just say that the OCFP has been advocating to the federal government to try to really reduce these requests. But our understanding is if they do come to you and a patient puts a request in for a travel note, this would fall within the CPSO's third-party medical report policy. So we are expected to provide them. Now the OCFP's presence message is coming out today, and that will include a script that can be used that outlines kind of symptom onset as well as the date of the completion of self-isolation. So that can be used as a reference to provide to patients. And the only other piece I would add is just we would ask the patient to ensure that they are aware of the requirements for their own travel. So their transit countries and destination countries, we want to make sure that they know what they need rather than pushing that burden onto us.
Thank you. And just to let people know, we have a new Confused About COVID that's coming out, or I think that actually is out, related to, you got COVID, what does this mean? And it talks a little bit about travel. So you might find that a helpful handout to provide to your patients. So Terry Weinberg has asked, we also know that rapid tests can have as low as 20% pickup for Omicron. So why is the message to the public, if a rapid test is negative, you're okay to go restaurants or a party? I will say this is also based on, I think Terry's attended our COPs, and Allison at the last session did talk about how the, pickup on a rat for Omicron is less based on some of the studies. I don't know, Zane or others. If
yeah, it is a good question. And I think they were sold a lot as this, like, we can get together if we do a rat. There's obviously this pervasive nature in the States where rats and in the UK where rats are very available, and they've really pushed that. it probably does offer some protection to say that you're not, horribly infectious that day, but I have absolutely seen people that have had negative rats one day and screamingly positive rats the next. So, it is as much as it is, not a silver bullet, there's probably a little bit that say that you don't have an extremely high viral load at that moment is an excuse to go out and do something crazy and have a very high packed gathering. Well, even in the original Omicron data from a big outbreak in Norway, where I think 100 or 120 people who went to a dinner party essentially got infected. I think a good chunk of them had actually done a rat test within 24 hours of coming to that gathering. So, again, it's not perfect in that sense. And I think, we do have to counsel patients. They're a good tool if they test positive. Even in a symptomatic individual, I've definitely seen rats, especially in our healthcare workers, test negative then positive 2 days later while they're having symptoms. So, they should only be trusted for their positive value. They can be used a little bit in healthcare for their negative value to bring people back to work temporarily. But outside of that point, I think that counseling around, you can do a large gathering with a rat, people have to know that they're fallible in that sense.
Well, and I think especially, I was going to say, I think, Zane, especially in symptomatic people, like I think that anybody with symptoms shouldn't just say, I've had a rat and I'm good, it's negative, I'm good to go. And I think we're seeing a lot of people sort of wish away their symptoms with a negative rat as opposed to just isolating for 5 days.
Yeah, and so I just wanted to again pull up the COVID, confused about COVID. We actually have a specific handout related to the rat, and we actually are very clear in that handout that it's not currently recommended as a screening tool to go to gatherings. The recommended uses might relate it to a formal screening program or kind of return to work in very specific situations, so work or school. So please do again refer your patients to that, because I think the government's messaging it's been hard for I don't think they've done a great job at continuing to keep the public up to date with their evolving guidance. So I think the next question, David, you were going to ask about you were going to answer about the Novavax vaccine, and are we looking at a fourth booster in the fall?
Yeah, I'm not going to answer the fourth booster in the fall. I'll let the infectious disease specialist talk about that. But on the Novavax front, the government's plan, if and when it gets approved, is to use it in very specific populations. So, there is a subset of people who are not vaccinated who have said that they're interested in a older technology vaccine like Novavax. And so I think it'll be made available on a very specifically, not widely, to that group of the population. And hopefully we will see an uptick in some people who've been holding out for a non-mRNA vaccine. But that as of yesterday, that's what we had heard at the government's vaccination table.
Thanks. I'm going to ask another question from Deborah Zaney just about vaccines for those under 5s. I think actually a number of people have asked that, and I don't know if there is any update, Zane, on vaccines for those under 5.
Yeah, so a little bit of development over the last week for Pfizer submitting its data for 2 doses of vaccine. So Pfizer had set up a trial for those for 6 months to 5 years of age for a 3 microgram vaccine. It was a smaller trial, and they used a surrogate endpoint of antibody titers, basically compared to 5 to 11-year-old antibody titers, to be able to do this study appropriately. There is also a Moderna vaccine for 6 to 5-year-olds, which was actually recruiting in Ontario for some time. I'm not sure if it's still recruiting, but also an ongoing Moderna study looking similarly. The interim analysis, at least of the Pfizer trial, showed that the immunologic responses fell below the non-inferiority threshold, and Pfizer went forward with a 3rd dose of vaccine for those kids to see if they could boost them above the non-inferiority threshold. There was safety, apparently, that showed it was fine, and some rumored reports, again, from people who had leaked the trial that said the efficacy was around 50% or so in terms of preventing COVID-19, although there were less than 100 cases of COVID-19 in the study altogether. So Pfizer has now taken this to the FDA. It sounds like the FDA or the White House actually kind of pushed Pfizer to take it to the FDA in order to analyze that data set. part of it would be to start the work in terms of approving once that third dose data is out there, and so be it. But it's also looking at this in the context of the Omicron situation, some of the data around reductions in MIS-C amongst individuals that even have a single dose of vaccine, and considering based on what limited data is in that 2-dose trial, that whether or not, there is a benefit here to even consider using whatever data we have to say that we should be giving that in children between the age of 6 months and 5 years. So that hearing is happening on February 15th. And so some of that data will be transparent then. It will take a decent amount of time to pass through Health Canada review. So I would not necessarily suspect it's going to be here anytime soon, but we'll see what the FDA has to say about it first.
Thanks. I know that there are still a number of questions, so maybe I'll just ask 2 more and then we'll just wrap it up. One just around if people have had 2 AstraZeneca or other non-mRNA vaccines, are they going to ultimately be eligible for a 4th dose? And when? Do we have any guidance on that? Because I think you had some really compelling data there saying about AstraZeneca really not being effective.
I mean, the good news is at least, and I didn't show the slides from the UK on 2 doses of AstraZeneca, and an mRNA booster, but they are acting like having 2 doses of mRNA plus an mRNA booster. So those people, as long as they get their mRNA booster, kind of go on the same track as someone that's had all 3 vaccines being mRNA, or even 2 of 3 vaccines being mRNA. So, even more incentive to make sure that those double dose viral vector vaccine people or single dose Johnson people in the community really do have access to an mRNA as a booster. But thankfully, it looks like those individuals, as long as they get mRNA, get put on the same track as mRNA only people in that sense.
Okay, that's really reassuring. Thanks. So Brian, I'm just going to ask you to pull up the last slides, the confused about COVID, just as we're wrapping up. And then Zane, I'm going to ask you the last question just about Halbrain's asking, what does the science say about the end of COVID? Is it coming soon, or will we forever be dealing with wave after wave of new and exciting variants?
Yeah, I mean, it's obviously hard to say that this is going to end. Omicron has set another level of transmissibility, and whatever comes after Omicron is probably going to be more, I presume more immune evasive than Omicron, or somehow transmit better than Omicron for its evolutionary advantage. The good news is we have vaccines. There is going to be some immunity that's derived from all these people getting infected. And so there will probably be more health system strain. I don't think that's not, but the future is a whole lot better than it was 2 years ago. We have therapeutics, we have better vaccines, we have more immunity, we'll have more stuff coming down the pipeline like nasal vaccines, pan-coronavirus vaccines, et cetera. And so we'll likely have hopefully have much more stability, but this virus is obviously very humbling. And it's also a nice plug again for the CMA and everyone else's stance here to really work towards global vaccine equity as part of this, as again, our duty to the world is also going to be a significant part of how we control this disease, more than just what's happening locally.
Thanks so much. So, I think there's still lots of questions, but we're going to be back in 2 weeks. And in the meantime, I know that there's an OCFP update coming soon, and they're going to be putting some more links out there. We'll also be posting our Q&A after the session. So thank you to everyone who came today. I wanted to just let people know that we've added some new resources to the Confused About COVID site, and we also have translations now in French, Korean, traditional and simplified Chinese, as well as on early next week, we'll have Spanish and Farsi up as well. The new resources, maybe next slide, I'll just say very briefly, are on children. Again, a great handout for your patients to know when to call the doctor versus when to go to 911 and what to do at home. Next slide, we have one specifically on pregnancy, and it highlights also this great handout from the provincial child, and actually I always get this this task force name wrong, but from this great provincial agencies, their great handout as well is highlighted there. Next slide. And then we also have one just on, do I really need a 3rd dose? And I think in particular, if you're older and are immunocompromised, Zane said, yes, you really do. So we try to put that there and also clarify who needs a 4th dose. Next slide. And we also have one around what happens after getting COVID. So this is, some of the common questions people have been asking. And people also, of course, are asking about travel. And so the third or fourth page on this handout does talk about travel as well. And we'll keep these up to date. For example, when UNASI guidance comes out around the recommended interval for dosing, we'll try and keep that consistent. Next slide. So our next session is scheduled for Friday, February 18th. We have a couple of panelists confirmed already, actually. So we're going to have an infectious disease specialist, Richie Murthy, who's from Ottawa, who's going to be joining us, and Dr. Ashley Verdun, who from Toronto works in a long-term care home and has been doing a lot of work to support long COVID. So we know that that's increasingly an issue. So thanks everyone so much for joining us today, and thank you for all your work despite all of the craziness around us and possibly a crazy weekend ahead for those of us now moving from Ottawa to the GTA with the protests. We're staying strong, and it's so amazing to come together to see your continued commitment to providing amazing patient care to your patients, and we'll do our best to continue to provide you with the answers that you need to do that. Thanks to our terrific panelists today, Rosemary Law, Ed Etchells, and Zane Chugla, who've taken time out of their busy day, and my co-hosts Mehle and David, who are always keeping up to date on the latest provincial guidance. So thanks to everyone, and also our back team, I should say, who does a tremendous amount of work behind the scenes to make this happen. So we'll see everyone in 2 weeks, and until then, stay safe.